My name is Jenna Adams. I am an infectious disease clinical pharmacist at UI Health and the University of Illinois Chicago College of Pharmacy. And it is my honor to introduce Dr. Stephanie Black. She is the acting deputy commissioner of the Disease Control Bureau. She focuses on healthcare associated infections and infection control in healthcare settings, in addition to community-based communicable diseases. Dr. Black is board certified in internal medicine and infectious diseases. She completed her undergraduate training at Cornell University, medical school at Temple University, and internal medicine residency and infectious disease fellowship studies at Rush University Medical Center, followed by 5 years at John H. Stroger Hospital of Cook County. She's a voting member of the Presidential Advisory Council on Combating Antimicrobial Resistant Bacteria. So please welcome Dr. Black.
Thank you very much. I'm trying, is this mic's working? You guys can hear me okay? Okay, all right. Okay, then we will get going. So I will say it was very challenging to decide what to talk about when I was asked to talk about emerging infectious diseases. There's a lot out there. I do have these stock holdings. Actually, I think we don't have them anymore, but I did. So I am just encouraging you right now, when you fill out your evaluation, if you want to hear about emerging infectious diseases that are like not related to antimicrobial resistance, then please write that on your evaluation. So next year we can really like hit some of these other diseases, or speakers can do that, because that's kind of what I struggled with. But I thought if you spent your day here for stewardship, then you probably do really want to hear about MDROs, but I could have guessed wrong. So because of that, I do have a couple of slides just and the links at the bottom of the slide are where you can get a whole lot more information if you want to know what is going on with measles. But I'm looking out and I'm seeing my peeps, and I'm seeing peeps I know and peeps I don't know. But if you're working in Illinois, then you know that we have been the epicenter, right, of the country recently for measles infections, where we had 57 cases associated with one new arrivals shelter, but managed to stop transmission due to a tremendous effort from the Health CDPH, IDPH's help, and lots of hospital partners. Patients had to be admitted for isolation. It was a huge effort, and thank you to all who contributed. But we do need to be worried about measles, particularly in unvaccinated individuals who are traveling both internationally but also domestically. So kind of check where you're traveling, but you guys are all vaccinated, I'm sure. So, and then next, I of course want to highlight highly pathogenic avian influenza, in which there are a total of, I was reading 9 cases, 4 that are following exposures to dairy cows, and now added to the list are 5 cases that are related to poultry. And at this time, there are 13 states who are have outbreaks among dairy cows. And so this is a major issue, and we're very interested in doing right-sized influenza surveillance as we approach the fall. Big topic. As you know, surveillance is done in wastewater looking for H5. We don't know whether those contributions are necessarily from cows or from flyover birds. So, you know, when seeing that, then we look at influenza cases to see if there's any change in human epidemiology. But that is the work, much of the work of what's going on in planning in terms of respiratory viruses for the fall. Okay, so sorry we can't talk more about that, but there's just too much to get to. So I wanted to highlight priority pathogens in terms of MDROs and XDROs as highlighted by the WHO, CDC, and then IDPH and CDPH have collaborated together to, talk about identified tiers of these MDROs. And so I will then talk a little bit about a gram-negative MDRO surveillance on a national and then also a local level, and kind of share back with you information that we've received from Chicago hospitals. And then also cover Candida auris surveillance data. I'd like to share with you also some novel surveillance tools for AMR. Very exciting genetic sequencing we've been doing to figure out what kinds of transmission patterns are happening. And then I promise that I will stop at 4:45. Like, we're just going to stop. So don't worry. But also wanted to highlight some other pathogens that you see on the slide here, including an upsetting phenomenon I've heard about through PACARB Association is this antimicrobial resistance in war, and how, war wounds are actually a really good setup for festering kind of infected wounds, and people can't get access to antimicrobials, and they end up with drug resistant, or they can't, not a consistent course because there's just not enough of that type of antibiotic. And then people, leave the war-torn country, and it's just kind of an opportunity for exacerbation of this global antimicrobial resistance problem. So we don't get to it there, you just heard that. And then I do want to feature a little bit about health equity in MDROs, because this is really kind of a new lane of work, I think, in every area, right, of public health, and it's part of MDRO surveillance as well. So that's an area that our group is really interested in looking more at. Okay, so I do want to talk about magnitude of the AMR problem, as quoted by this macro economist, who, this is an oft quoted statement, so you should hear it and know it. But the concern is that by 2050, we could have as many as 10 million lives a year that are at risk for drug-resistant infections. Today, it's estimated there's around 700,000 a year. And the real worry for all of this is that procedures that are fairly routine, right, like abdominal surgery, C-sections, joint replacements, and the like will actually, for some patients, at least those who are immunocompromised or on chemo, be just too dangerous to do. And so that is a really scary specter. And this is kind of what's called a Rose diagram to kind of describe that. I'm sorry that I didn't bring a pointer, but on the innermost circle is kind of where we're at now. And then that purple funnel at the top is kind of what is projected for 2050. And you can see that AMR infections there are more than cancer, more than cholera, more than diabetes. So this is a huge concern. It is a global threat, and something that I'm happy that you're here to consider. Stewardship is a huge part of combating AMR. So I did want to highlight this important paper that was published in 2022. The authors are a consortium, the Antimicrobial Resistance Collaborators. They looked at 23 pathogens, 88 pathogen drug combinations, across 204 countries. So this was a huge undertaking. And I looked it up. There's like 256 countries, so something like that. So it was a huge study. And these graphs I have here on the left are the most common infectious syndromes, which led to fatal outcomes. And so those include lower respiratory and thorax infections, so like pneumonia. I mean, it's kind of what you would think, right? Second is bloodstream infections, and third are intra-abdominal infections. And then on the right side of the slide in the red box are the 6 most common pathogens leading to infection. And at the top is E. coli, and then Staph aureus. And Staph aureus, as I'll point out to you on some of the national data slides, like orders of magnitude higher than all the other infections. Like, so a tremendous contribution. And so encourage you to take a look at that paper if you wanted to see more. And so these are, I didn't know this existed actually until I was preparing for this talk, but the WHO actually does put out a list of priority pathogens in order to help guide policy. And this is in the critical group are Acinetobacter baumannii that are carbapenem resistant, and the Enterobacteriales that are both, the next two are Enterobacteriales, the first resistant to third generation cephalosporins, and then next that are carbapenemase resistant. And the way that, and Salmonella typhi, some of the other pathogens I'm going to talk about are considered in the high group. The way that these were prioritized was there's a whole elaborate diagram if you want to look at it. We don't have time to go all into it, but obviously fatal outcomes, the incidence, the burden of disease, the trend over time of how much resistance exists, how transmissible they are, how treatable they are, what's in the pipeline for these pathogens. And then it turns out there's also fungi always get kind of left behind. We don't talk about them enough. So there's also a WHO list of priority fungal pathogens. This is from 2022, and in the top there, it's hard to see all the way on the right. The top right is our favorite, is Candida auris. But also up there, important to know is Aspergillus fumigatus, along with Cryptococcus neoformans. And this similarly is prioritized based on similar criteria that I'm not going to go through right at this moment. And I will just take a moment, and I did not get to pair my slides like I expected last night because we had a slight emergency that I needed to respond to. So I will fly through some of these slides. These are two really helpful reports to take a look at. And I'm sure you've seen the CDC's issuance of the priority pathogens and how COVID affected our MDROs. So we'll just high level go through some of that. And the other is the Wellcome Trust, which puts out the global response to AMR. This is an excellent group. If you're interested in reading kind of a summary of what's going on globally and what we can do about it, this is an excellent document. And that points out how, COVID did lead to more understanding of infection in some ways, infection prevention and control in more facilities, like in long-term care, and put more of an importance in that space. Although it's a lot, a lot of the focus was on controlling transmission for respiratory illnesses, which took attention off environment, and hand hygiene is always so important. But also there were, the possibility of young researchers kind of diverted to going into working on viral infections instead of bacterial infections. And stewardship kind of took a back seat a little bit while everybody was, identifying who's positive, who's negative for COVID and isolating appropriately as everybody had to do. And then a decrease in funding. And so these are the CDC priority pathogens. And some of the data, as you might expect, is not terrific after, starting in 2020. And so I'll just go through these very quickly, but I do want to set up, because what I want you to appreciate is kind of the relative contributions of the different pathogens. And so the vertical bar all the way to the right of the slide at the top, you can see that that's the total number of infections caused in 2020, and the contribution that are hospital onset drug resistant are in the light blue. And notice that CRE is responsible for 12,000. Wait till I show you MRSA. But it's still, this is a lot, and there's substantial morbidity and mortality, of course, from CRE that we worry about. And then with ESBLs, these are infections that used to, we would treat urinary tract infections with an oral antimicrobial, right, as an outpatient. And now some of these require carbapenem treatment, so that patients need to be admitted for IV antibiotics. So an increase in this pathogen as well as carbapenemase resistant Pseudomonas aeruginosa, and that number going up a little bit from CRE 12,000 over all the way on the right, 28,000. There was a decline. This kind of held steady. At the top bar, I cut and pasted from the table to kind of show the graphs next to each other, but shows the trend over the 3 years prior. And this is what I really wanted. I mean, look at that contribution of MRSA to causing infections overall, and still like 279,000. So it's very eye-opening, I think, to see that. But of course, a high priority for all healthcare facilities. But rising proportion of hospital onset MRSA infections. And then, of course, we see this increase in Candida auris, which landed here in Chicago early on in 2016. So prioritizing containment is the goal. This is the framework set out by CDC with tier 1, tier 2, tier 3, and tier 4 pathogens. Tier 1 being the most concerning. And I'll just flip through those pretty quickly, but novel refers to a pathogen that we never or rarely see, and I'll get into an example in just a moment. Targeted are pathogens that the local health department, along with the state, sort of select. These may be regional, so they may differ from one part of Illinois to another. And the response elements are highlighted at the bottom of the slide. And so these are the various, many of you would have been a part of when we call you up and we want to know what's going on in terms of where, what room people are in, and mapping and consideration for personal protective equipment, along with laboratory surveillance. Really, environmental sampling is rarely done. And of course, IPC measures. So in the green are interventions we always do, in yellow usually, and then blue sometimes. And for tier 1, this we go all out for, because these are pathogens or genes that we do not see. MCR1 is a good example. This happened in 2016 in a patient in Pennsylvania, and there was like an all hands response. There were about 100 people who were 200 people actually who underwent surveillance testing. This person had not traveled internationally, no livestock exposure, and had repeated admission to 4 different healthcare facilities, but culturing did not determine a source. And actually, this is an example of when wastewater kind of would have maybe been helpful for AMR, maybe. So that jury is out, and we'll get to talk about that when I talk about novel surveillance mechanisms. But just to go through these a little bit more, tier 2, there are less kind of interventions that are there are more, I should say, that are done rarely. Right, there isn't household or contact screening. There's rarely healthcare personnel screening. And examples of these are when we have in Chicago clusters of a like CRE with a less common mechanism. Now, NDM is common, but if it's in a new facility where we haven't really seen NDM and there's a cluster of cases, an epi link between cases, then we consider that tier 2. Otherwise, it's tier 3. I'll show these to you also on another slide. And then tier 3 are pathogens where there is more advanced spread, there's more around, but it's not yet considered endemic. And then finally, tier 4 are pathogens that are considered endemic to the region, but are targeted by public health. But we usually do not do extensive investigations as a result of these pathogens. And So Chicago specifically, these are the tiers, which I've sort of shown you in light blue on those prior slides. But a little bit hard to see, but for newly or recently identified facility like SNFs, not VSNFs, but SNFs, assisted living and dialysis, we consider to be for tier 2 CPOs that have NDM, IMP, or OXA48 or VIM. And then for more VSNFs or LTACs, where we see a lot of these pathogens commonly, even Candida auris is tier 3 for us, kind of sadly. But notice it's tier 2 for SNFs. And then finally, for acute care facilities, this is when we're really looking for the EpiLink. If you have several cases of a CPO with those particular genes like NDM, OXA48 or VIM, then we do generally inquire about an epi investigation for those. And then I do just briefly want to show you this, but I'm not going to go through it because that'll take too much time. But these are currently the information sources by which we draw what I'm about to show you. So I'll show you back kind of the surveillance that we see through the XDRO registry. The submissions of information through INEDs, the case report forms, allow us to look at risk factors. That I know has been, that's a ton of work, but unless we get that information, we can't sort of turn it around to you. So as we ask about case report forms and the details of patients, you know, particularly around changing epidemiology of Candida auris, that is the reason for that ask. I believe it is new now that the request has been made to enter those both clinical into XDRO and INEDs, and I apologize for that double data entry. Okay. I'm gonna keep going now. All right, so there are some caveats. XDRO is not deduplicated, so you know there may be multiple cultures per person represented. So I'm just going to go through these quickly. These are surveillance that we get through our point prevalence surveys and also clinical reports from you. And I'm gonna, the lens kind of goes in and out a little bit here. So the time frame, this is scaling back to 2019 through May 2024. And you know, the major pathogen overall is carbapenem-resistant Enterobacterialis with crab. You know, we have less uniform data on that. IDPH was doing a study in earlier years where crab laboratories were submitting carbapenem-resistant Acinetobacter baumannii. And in the pink is CRPA. So these are the reported the mechanisms. So CRE by mechanism, and this is again 2019 to 2024, and majority are mechanism unknown, and then of course KPC, but NDM is the next most common mechanism. And for crab, OXA is the most common for when it is known. I understand. I think that IDPH will be splitting out the different mechanisms in XDRO in the future. So we'll be able to see what's 23, 48, and the various OXAs, and then CRPA here by mechanism. And VIM is the most common, but you'll notice the N is way smaller than the others, right? It was like 3,000 for CRE. So this is much less commonly found and also less commonly reported. And then this is showing you some data by the facility type. So here are tier 2, so less frequently encountered pathogens that we see in VSNFs and LTACs. And then just gonna flip through these quickly. Tier 3 we see in VSNFs and LTACs, maybe about, you know, around 40 to 50 a month, but these, the contribution of course, of our PPSs is shown here, because in the dark blue are Candida auris screening cultures. The light blue are clinical cases. So this is a little bit of a gamish, like some screening, some clinical. We need to be able to break those out to share back with you. And I'll show you some bloodstream infection information. So this is a little bit of a combination of those things. So the dark blue bars, which are so, the majority here is due to screening point prevalence surveys. And then here we have mechanism unknown, CRAB represented in orange, and then CRE, KPC, the tier 4. And then for acute care hospitals, clinical, look at the Candida auris clinical is light blue here, same color scheme. And it's quite a bit of Candida auris that are seen. And we do try to attribute to the facility, we look at, we do some address matching so that the attribution is, correct. Interesting that we are seeing that. I'm going to keep going. I wanted to share back with you. This is bloodstream infections now from 2019 to 2024. And Candida auris, sorry for the color switch there, but Candida auris is shown in orange on this slide. And I mean, notice the increase in bloodstream infections caused by Candida auris, and more about that coming. So let's talk about Candida auris a little bit more. So first identified in 2016, and then we see it just over the years increasing, spreading across the country. And of course, Illinois becoming, since we got the head start, darker orange. And then, of course, here we are now, and Illinois is considered, of course, a high burden state. We are in the process of finalizing our the half-yearly report. This is a little bit of a preview. This is just clinical and screening cases from 2016 to 2024, with clinical cases being in dark blue and screening in the light blue. And of course that we see lower numbers during the pandemic because we were not doing as many PPSs then. These are a breakdown of the cultures by specimen source. This is again that longer time frame, longer scope. Most of the specimen sources are from blood and then urine. And then I'm just showed you, this is for our first quarter of 2024, and that is inverses, so more urine specimens. This is a challenge to everybody clinically. I know, because right, is it a real infection? That really needs to be looked at, especially because the echinocandins are the treatment of choice and they don't get into the bladder. So that I think we need to look at that a little bit more. We couldn't cross match these with NHSN, but that would certainly be interesting. And so this is Candida auris prevalence by different facility types. And this is just, I'll flag just the first quarter of 2024. And do notice too that the number of facilities represented are really quite small. Although, it's like half of our VSNFs, and there are a few LTACs too, of course, it's just one represented here. So like 30%. But SNFs are appearing on here. So we are concerned seeing more bloodstream infections. So these are bloodstream infections due to Candida auris over the time span 2019 to 2024. And this time the color bars represent different facility types, and the SNFs are in pink. And so I would just point out to you, you see the increase in C. auris cases that are happening. These are bloodstream infections that are happening in SNFs. I think that nationally, numbers were down for NHSN from 2021 to 2022 for these device-associated infections. We have seen a flip where in 2021 we did see some increases. This is data from 28 Chicago hospitals, mostly intensive care units, the vast majority. But from 2022 to 2023 did see a decrease The increases previously might be because of larger patient volumes and decreased staffing. But let me keep going because I definitely want to get to these novel surveillance mechanisms. All right, so as we've discussed already at the start of this talk, just how big of a deal global, the issue with AMR globally. So I think we've established that there's a burden of disease. And it is interesting to be able to collect data on, maybe neighborhoods that we aren't necessarily, we're not doing surveillance cultures in. And maybe it would be interesting to trend over time. But I think we need to really make more of a case for what we would do about it. I'm kind of on the fence about whether this, what I think this is early days for AMR in wastewater. I do think the example of the MCR gene, that patient in Pennsylvania, where you have a relatively rare gene, to see it pop up in wastewater would be significant. And you might then be able to kind of work backwards, see what the facilities are that are contributing in that region, and then do like a PPS. So, I mean, it's possible that there's something there. But I think that it remains a little bit to be seen. So I'm on the fence about that. But I do want to talk about this transfer network and genomic analysis. And I should have mentioned my colleague, Sydney Theipen, who made some of those other surveillance slides. And I will mention my colleague, Kelly Wobble, who many of you know, who has moved on to Michigan, but who gave a talk on this at CSTE, very interesting. And I'm just going to give you like a snapshot of 2 clusters so you can get a sense of this. But just a quick phylogenetic tree orientation, and I am really wishing I brought that pointer. But so every branch point represents a divergence. And so the length of the horizontal line indicates the single nucleotide polymorphism differences. So how different one isolate is from another. And the vertical stack means that those isolates have identical sequences. And so I'm going to talk through 2 different clusters. And this is an example of intra-facility transmission. So all of the blue circles are isolates from one particular facility. And so on that, the red bar is highlighting that they were all collected on the same date. So those are all blue squares. You can see that. And then also they were collected from the same floor. So all dark blue squares. But moving over to the room, it turns out that these patients were all in different rooms. So collected on the same date and from different rooms. And also the last specimen here was collected at a different time in December of 2019. And so this taken together is really suggestive that intra-facility transmission is occurring. And I should have given this a little bit more of a setup. These isolates were all obtained from stored point prevalence surveys that our team has done over the years. And we got these from the Wisconsin ARLN, who stored those specimens. And so now we're able to get them back and kind of look at the relationship, both in intra-facility, and then the next cluster is descriptive of inter-facility transmission. So here again, the colors all represent the different types of facilities. Orange VSNF, blue LTAC, one LTAC, and then light green another LTAC, and then a rehab facility in the dark green. And so here we see LTAC1 admits to VSNF1, and the rehab facility, LTAC2, does the same. And then finally, the rehab facility discharges to VSNF1. We cannot tell directionality here, but it's clearly these patients are shared among these facilities, and so are their pathogens. So are their with which they are colonized. So it's good, evidence to show, I think, administrators and teams that transmission is occurring, and helps to kind of identify where you might intervene. Like, should you be doing admission screening? Well, if you're one of these facilities, that might really help. So I think that this is a practice that will have more and more usefulness. So I wanted to share that with you. And then moving on to talk about, again, burden of MDROs, is this is an editorial paper that is about some of the major intervention studies that were published by Dr. Susan Huang's group out of UC Irvine. And there's two major papers, and I don't have like a lot of time to get into these. But the one on the bottom is doing decolonization. So the decolonization is using chlorhexidine bathing every time a patient is bathed, and then nasal iodophor, and it's given like twice a day for 5 days on admission, and then every other week, another course. And so that is the decolonization regimen. And in both, so the study that was published in JAMA is a consortium of healthcare facilities, 16 hospitals, 16 nursing homes, and 3 LTACs. The other on the upper side is the same sort of decolonization among 28 nursing homes. And they were able to show a significant decrease in hospitalizations due to infection with the use of this decolonization practices. But the editorial does talk about the fact that there are two one, they both have editorials, and really that this is a very intensive practice, and what I just described is very labor intensive. And also, the direct implication, I mean, there were other practices going on like skincare, making sure wounds were attended to, and the individual contributions of the chlorhexidine versus the iodophor were not measured. But I think the major message that that going it alone is no longer an option. And whether you look at that from a facility standpoint about who's in your network, I think I've shown you some data, right? Like from the genetic sequencing to on these studies, that you really want to be in communication with who's transferring to you, who you're transferring to. But then I'll also say, your health department, your local health department does want to work with you on trying to control these. So I just highlighting that going it alone, I really liked that. It's no longer an option, and we need to work together. And so to that end, we are actually going to be working with some facilities looking at the effect of bathing, because that was one of the criticisms too. Like, if you could just bathe patients better, then, can that decrease the MDRO prevalence and decrease admissions due to infection? So that is something, that's very important, but it's also very hard to bathe people correctly. Like, we need hot water or hot wipe. Like that is a tall order. It's hard to do. So it will be interesting to see kind of the results from I think from that work. And so just to mention drug-resistant aspergillosis, this is a huge deal for people who are very ill, right? People who have different kinds of malignancies or on medication that results in defects in cell-mediated immunity are really at risk for fatal outcomes from aspergillosis. And important to note that in countries that have been using azoles on agricultural products, those tulips, you can develop drug-resistant aspergillosis, and they have seen an increase in UK and Netherlands in vitro resistance. They're from 1.7 to 6% up to 20%. So very concerning. Do want to highlight the fluoroquinolone resistant Salmonella typhi. And I show these two graphs. Sorry, the numbers are small, but Salmonella is at the top of both lists. And these are lists of the most common causes of foodborne illness resulting in hospitalization on the top graph. And on the bottom is those resulting in death. And again, Salmonella is the top cause. So a concern, and also international travel has been associated with an increase in odds of quinolone non-susceptibility. So on the left, you can see quinolone non-susceptibility is much higher in that the red bar on the left than the right. Sorry, it doesn't really, I don't think it's showing too well here, but Salmonella infections, there was somewhat of a decrease, but there were fewer reports. Salmonella typhi in particular continues to have resistance. And then Shigella infections. This I do want to highlight. We've seen locally ESBL Shigella. Our recently graduated Epidemic Intelligence Service officer published on this ESBL, and we worked with a local hospital who identified the cluster and let us know about that, and we appreciate that. This means, in those at risk for having relapsing Shigella infections, really important to get antimicrobial susceptibility tests, especially if somebody returns with a recurrent infection. You've got to send that for AST. And our epidemiologist, Shamika Smith, is also in the process of putting this data brief together, where she went through INEDs from 2018 to 2023. There were 320 isolates that had AST done, and showing the relative resistance. Many, 60% were resistant to Bactrim, and then just north of 40% were resistant to ampicillin. And we did have some resistance to ciprofloxacin. And so these are like the oral agents to treat Shigella with. And then looking over on the right, showing the percentage of Shigella isolates that were MDR. There was a slight increase. There were some more MDR cases represented among Sony isolates, which is what Dr. Faraday had published on, and what was identified among a cluster of MSM. And that is the group at highest risk for having MDR Shigella, but it has also been described in homeless individuals. So those are other populations to be concerned about. I do want to mention drug-resistant Neisseria meningitidis. We have not in Illinois, and in fact in Region 5, and I confirm this today, that there has not been recent ciprofloxacin resistance in our area. There was one case in 2021 of dual resistance. But CDC is on the lookout. There have been an increase in Neisseria meningitidis cases kind of across the country. We have definitely seen an uptick in Chicago. We put out a press release about it in mid-May. But this is definitely something to be aware of and to watch for. Every isolate that is obtained from patients is sent to IDPH and then on to CDC for resistance testing. We are looking into doing whole genome sequencing locally. So that will be helpful to have. And I know this is a wordy slide, but on the right, there are the recommendations for what to do if there are 2 or more invasive meningococcal cases, or the cases that you do have represent 20% of all reported meninge cases that have cipro resistance. So we will let you guys know. We follow these cases, every one of them, very closely with getting contacts appropriately prophylaxed. And this is just a blow up of what we've seen in the region, but nothing recently. I have talked a little bit about the MDROs in war-torn regions. You on time. This is an MMWR published out of data from Ukraine. And where in a survey in 2016, 2017, they had only maybe, around 6% of their Enterobacteriales had resistance to the carbapenems. Granted, this was relatively few patients, but my gosh, what they're putting up with, and then also doing surveillance for resistance is impressive. But this survey showed that 50 of 353 patients who had healthcare associated infections, 60% showed resistance to carbapenems. And so highly concerning. And I know from hearing some lectures from folks who are working in these war-torn areas that really the problem is you just get some antibiotics in the operating room and then people get discharged and they get whatever antibiotics are available. So it's a tragic story for many reasons, but AMR is one of them. Okay, I do want to mention an equity focus on AMR. We know that minoritized patients, specifically non-Hispanic Black individuals, are less likely to receive timely antimicrobials and may need to go to hospitals in lower socioeconomic areas where there may not be the same sort of resources to make sure that appropriate interventions are in place, as patients are being evaluated, like in the emergency departments. And so I wanted to showcase some work done led by our CC Pagosi at CDPH, who, among others, also put together this health equity index. And that was built on these different parameters on the left side of the slide. And it's how we have prioritized where we are doing our infection control assessments. This has dictated where we go. And so there were kind of 4 different categories. And so the contributions to that health equity index are, the infection preventionist to bed ratio, the percent of transfers to skilled nursing facilities, their annual standardized infection ratios for device-associated infections, and then the percent of patients on Medicare and Medicaid, and also this community hardship index, which details, patient unemployment, age, dependency, what's education levels, per capita income, all in the American Community Survey, and poverty by zip code. And so by applying these, we saw this difference when comparing the highest and medium priority groups together, saw that those device-associated infections were 2.5, higher than expected, and the hardship index was 69 compared to a hardship index of 29 in the lowest priority, better resourced facilities. And same, the percent Medicaid, Medicare patients higher in those highest priority compared to lowest priority, and more transfers to SNFs too in the highest priority. And so we have focused on those facilities and will continue to do that. And we are also interested in collecting more data on race ethnicity. So that is my conclusions are that it's really important that you are here today because stewardship is so important to reducing the environment in which these MDROs can be cultivated and spread. I've emphasized the importance of understanding your transfer network, know who you're transferring your patients to, but know who is transferring patients to you. And great to be in touch with people about that. We are also trying to set up calls among our facilities to get people, people to really to talk with each other and know what is going on. Important for community acquired drug resistant pathogens to be considered considered in the right epidemiologic context, and also keeping that health equity lens in mind when targeting limited resources. So I do want to acknowledge many folks on the CDPH team, also at Rush University Medical Center, for their work through the Regional Innovative Public Health Laboratory, doing that sequencing with us. And Doe, we all miss Doe, who, if you know, Dr. Kim has moved on to work at the Milwaukee Public Health Lab, where he is on staff for the RNC. So thank you for your attention, for staying till now. And I ended 5 minutes early, so that's good. But do please do give feedback on that. Like if you really wanted to hear me talk about other infections, please give that feedback. I will not be offended. IDPH will not. They, we want to. The organizers, thank you for the invitation to speak, but you guys want to know too what everybody wants to hear about. So do give us some specific feedback on that. Yes. Yes, we do, and are reporting out on that, right, Larissa? For Candida auris specifically, less well for the other, and I think we really want to describe that. It's a great question. It's, it's just that the snapshot that we have is 2 snapshots in time, and we don't want to make too many assumptions about that. And, were there other clinical instances in between? But we do know for sure that patients go from positive negative to positive negative. But I appreciate the question. We are going to be sharing like the number. I think it's a maybe 25% or some that we know of, but you only know about the people when they're colonized beforehand because you happen to catch them. So it's a little skewed. Yeah.
Why do we have to keep people with Candida auris in a private room for their interested in the building?
Yeah. So because Candida auris gets into the environment, much like VRE, I think there's concern for, it's, colonizing a neighboring roommate. I think the idea of putting 2 Candida auris patients together, residents together, we have, somebody correct me if I'm wrong, but we have said that that's okay. You can but ideally they'd be in their own room, but they can be with other individuals with CRS. You don't want to put them with somebody with another MDRO. Just because the problem is, like I was, it gets the Candida auris gets not only, it gets into the environment on like windowsills, but it gets on the handrails of the beds. And so it's just very easy to transmit on the hands of healthcare workers to other residents. And then people, the mortality, like substantial number of people who are colonized do develop infection.
It's not like strict isolation. It moves around. But I wanted to ask, like, because I called CDPH.
I see.
They said it has to be in a private room for his entire.
Oh, I'm sorry. So you're asking about whether he can go to activities outside of the room? Okay. Yeah. Uh-huh.
Why do it have to be like, like in a private room for his entire in the building? Like a catch-22. You can roam around the building with the rest of the residents. Everybody has to sleep in a room by yourself. That's what I'm.
Yeah, you can be with somebody else with Candida auris. You just can't be with somebody else who's negative. And you're saying that they can go do an activity with it. Yeah. But the activities equipment should be wiped down, between residents, and people should be, washing their hands in between. I think it's just lowering the burden of that transmission possibility in the room because it takes over, like C. diff. Takes over the environment. So it's just easy to transmit then to a neighbor. So like best practices are to keep it separate. I think you don't want to take away their whole, like if you're if you, I mean, that's the reason for EBP, I think too, like you don't want to take away all of their activities because they're deemed to be sort of chronically colonized, right? Like, as I was saying about this positive, negative, we don't want to take people off. Does anybody want to add? I'm
just gonna say, EBP is supposed to be intuitive. So when you're looking at what your person's doing, how high contact of an activity is happening outside of their room. So I think that's part of the reason why they should be in a room by themselves. I don't have any CRs.
What? Have you done swabbing? Sorry.
Coming out and people are like, well, what about therapy? What about this? What about that? Like, why do we have to EBP after this? So I think you have to look at like, what are the activities that this resident is doing outside of their room? And that drives what you do versus what's in their room. They're touching everything. They're laying on their bed. They're sitting in their chair. They're touching all the things. There's gonna be way more CORs in the room. So I think that's what to your point, CORs is gonna be more likely in the room. So you don't want other people to end up with it. So it's like the prevention of spread.
And you have to be really confident in things like their hand hygiene.
Yeah.
And things like their clothing. Before you allow them on EVP versus.
Okay, where are my 5 C's? 5 clean clothes, clean. Where's Deb? Anyway, but to your, like, I mean, the whole, everything, the whole body, the wheelchair, everything must be clean when they're I mean, you have to be good about that. Was there another? Yes.
With regards to EBT,
Oh.
if it's not an isolation precaution, what is the best location for the carts? Inside or outside?
Outside. Okay.
No. We can still keep doing questions, but anyone that has, that wants CE, please come see me. I have the sheets.
And it's 4:45, so please feel welcome to come up and I can answer your questions, but I want to let people